Okay. Well, my name is Frank Lexa. I'm the CMO of the Radiology Leadership Institute, and it's really a pleasure for me to thank everyone for participating in this session. You have an extraordinary set of young leaders here, and I want to thank Amy Patel and the other organizers for pulling this together. We have 4 tremendous speakers who are going to talk to you about what it's like to be a leader in a crisis. And we talk about crisis leadership at the RLI, but it's far more important to hear from people who are actually living it and doing it. And that's the goal for today. And then I'm going to introduce one person who's going to be moderating this and introducing all of them to you. This is Dr. Andrew Moriarty. I had the pleasure of meeting him when he was still finishing up his training. And he's done a lot of his work in the great state of Michigan, where I happen to have been born. So that's an extra point for him, but he is just a tremendous example of a young person taking on leadership roles. And I could have predicted that he would be a leader, from the day I met him. So I'm thrilled that he's involved. I'm going to turn it over to him to introduce the speakers today.
Well, thank you very much for that, Dr. Lexa. Yeah, I am just happy to be here with several other YPS members who are clearly leaders in their practices and definitely across the field of radiology. So I wanted to mention that this is part of the YPS webinar series that we're doing. We lost a lot of potential for content when the annual meeting went virtual this year, and you'll see a number of webinars that are sponsored by the YPS as we go throughout the year to try to give you more content during the course of the year and to really tailor your learning as you work in early practice. So we're fortunate to have 4 outstanding leaders here. Dr. Amy Patel is a breast radiologist and current chair of the ACR YPS. Dr. Dan Ortiz is in private practice down in Georgia. Dr. Schoppe is private practice in Texas and a member of the ACR economics team. And Dr. Melissa Chen is down at Baylor in Texas and also a member of the ACR and ASNR economics team. So with that, I'm going to let them speak and tell about their experience during the COVID pandemic, especially as young leaders.
And why don't we start with Dr. Chen, if I'm getting the alphabet right.
Thank you. So I currently work at MD Anderson in Houston, Texas. I was asked by my division head to help lead efforts for the COVID, sort of COVID operations as sort of figuring out, how do we safely take care of patients while COVID is going on. And it has turned out to be a huge endeavor. I will say that being asked to sort of be in this position, there were several things that happened initially when I started at MD Anderson that I think sort of led to this opportunity. Initially when I joined MD Anderson, I looked for opportunities where I could meet people outside of the division and meet people who were, find opportunities basically for junior faculty, just because of the huge hierarchical structure in an academic setting. So I ended up joining something called the Junior Faculty Committee, and then I am now chair of that. That has actually led to a lot of opportunities where I meet a lot of the leaders of the MD Anderson institution, which led me to have a good chance at an opportunity to become, I was recently appointed to be the something called the Cancer Network. So it's the MD Anderson Alliance of imaging center or of cancer centers across the United States. And so I was appointed, or I basically applied for this position and was given as an associate executive director for this cancer network. And I think that part of the reason why I got this position was just because I got to know some of the people involved in the cancer network, sort of the leader of the cancer network. I also made it known to my chair that I was very interested in leadership type positions, administrative type positions. And then that's when I got to know my division head, because when I interviewed for the position, my division head, was a part of the interview process. And I think that he learned about my interest in leadership and all. So it's a long-winded story, but there were multiple events that led to multiple, I guess, things that I took advantage of at my institution that led me to sort of early on as a junior faculty be asked to lead the operational efforts for the the diagnostic imaging center. And so it's been really a great opportunity for me. Just to give you perspective, we image, I think the revenue for diagnostic imaging is over $1 billion a year. And so it's a huge operation. And there are, technologists, nursing staff, and faculty that sort of roll under this operational team where we're trying to help ramp up operations. And so it's continued. I will say that I don't think that anyone imagined how big the team would get and how much work it would be, but it sort of grew. And I think one thing just from the leadership opportunity that I had, I think you basically make of it, if you're given that opportunity, it's sort of the sky is the limit for how far you take it. And if you take it, no one's going to tell you to stop. As long as you fall within the political boundaries, as long as you're not offending anyone, I think if you're given small chances to do something, you should not limit yourself to what you envision yourself doing. And so that would be something that I learned, and I'll stop there and let everyone else introduce themselves. Thanks.
I think I'm next alphabetically. I'm Daniel Ortiz. I'm in private practice down in Georgia, serve mostly rural and small hospitals out in community areas in northern Georgia. About a year and 3 months into practice now. I got involved in sort of this COVID leadership stuff back early on, sort of by happenstance, as I happened to be at the hospital that was the first endemic hospital in our area that week. And that sort of led to us working through, workflow through radiology department, sort of reporting and things like that. And as time has gone on, it's shifted more from, breakout mode to trying to work our way back to normal. And that's really manifested itself by moving our majority diagnostic folks working remote, which we were doing during the high period of the endemic, more towards putting more people on site and increasing our outpatient imaging. So really, it's been conversations back and forth with hospitals, making sure that we're increasing our interventional procedures that were put on hold and things like that. We've had a couple of hospitals here and there, just as local outbreaks happen, we have to pump the brakes a little bit on on-site presence, maybe for a week or two. And that's really been the bulk of what we've been dealing with. We've also have worked on fully implementing us taking on our own nights and sort of working through the scheduling, just sort of general practice type issues as we go through the pandemic. We're looking forward ahead to the fall and winter and just sort of scenario planning to figure out ways that we may have to adjust in the near term or long term. Also looking at staffing needs as we continue to grow our practice and trying to anticipate, good growth versus any things that might come in the way with that in the future. Additionally, just looking at the local landscape, seeing how other groups are affected, and just generally in this whole health care marketplace, figuring out ways to have strategic partnerships with other groups in our local area and things like that. Just working forward. Those are sort of the big things that we're dealing with locally.
I think I'm next. Hi, my name is Amy Patel, and I am a breast radiologist. So by strict definition, I'm actually employed by private practice. I am employed by a practice in the Kansas City area, Missouri and Kansas area, called Alliance Radiology. And through Alliance Radiology, we contract with multiple hospitals and more underserved health systems. So it's interesting because on top of that, in addition to my position with Alliance Radiology and all the hospitals we contract with, our main hospital, which is in Kansas City, Liberty Hospital, I'm the medical director of the breast center there. So for me, during this whole current COVID, during the pandemic, it's been kind of tricky because in terms of coordination, because, they're particularly with some who may head a section like in pure academics or even a private practice, all the facilities may be under one system. Well, mine aren't. And so coordination during the pandemic was from the beginning a bit tricky. But the good news is where I practice, all of our rural hospitals that are smaller kind of look to our main breast center in the Kansas City area. All the technologists are talking. We're kind of like one big family, which has been really helpful that through all of this, we all were very cohesive before the pandemic hit. So I'm not only am I the medical director of our breast center at Liberty Hospital in the Kansas City area, but I'm also overseeing breast imaging for 7 rural hospitals in Northwest Missouri and the indigent health system in urban Kansas City, Samuel Rogers. So in the beginning, obviously these hospital systems were looking to me for leadership. What are we going to do? Where I practice, particularly in the heartland of the United States, there was another tricky layer involved, and that was, those who didn't want to shut down non-urgent imaging, even though CDC had recommended, to shut down all non-urgent imaging. So we had those discussions with particularly some of our rural hospitals, and it wasn't a matter of political polarization. I think it was a matter of survival. I think a lot of these rural hospitals were afraid that if we ceased imaging so drastically, that could, their hospital systems could take a very large hit. So having to sort of navigate all of that during the pandemic was quite interesting. But we ultimately were able to come up with a game plan, not just for our rural smaller facilities. I will say, and just in general, the urban, more indigent health system and our main breast center in Kansas City, they definitely, strictly adhere to CDC guidelines. They waited the longest to resume non-urgent imaging. And a lot of that has to do with the numbers. We were seeing more cases in more urban areas. They really went by the book, whereas our rural areas, we had to compromise in certain ways, certain patient scenarios. So I learned a lot about leadership during this time. I learned a lot just assuming this position with all of the balls that I juggle with all of these facilities and health systems. But it definitely added a whole new layer with the pandemic and really kind of showed me my true leadership colors. So I am grateful for the experience. I hope we don't have another pandemic while I'm still practicing. But if we do, I think that I've learned a lot from the process, and I'm going to be prepared for all of my facilities, regardless of geographic location. So thank you, and I'll hand it over to Kurt.
I appreciate that, Amy. So I come at it from a little bit different perspective. I'm in a large private practice group in Dallas-Fort Worth, a little over 220 rads. And so we had a central COVID kind of steering committee, as it were, who could coordinate among our multiple health systems. So there was that complexity. I also happen to be the chair of the department at our county hospital. And so this is one of those leadership lessons, if you take away anything from my brief spiel, is that don't underestimate the role of radiology or radiologists. At the beginning of the pandemic, and I remember communicating with Dr. Ortiz about this by text, is the role of radiological imaging when testing was not available. And that's how I ended up on the Tarrant County and hospital systems COVID steering committee, just because radiology had a clear role in the beginning because we did not have good workflow. We did not have testing available, and they needed to use radiology, however imperfect it was. And no matter what some of the more genuine academic literature was saying about the use of chest CT in COVID, it was very important on the ground in the early days to get it sorted. And then my role really evolved from anything related to the radiologists or radiology to my task. It was protecting our technologists, nurses, and the rest of our staff. And so when we work through workflows, protocols, policies, and everything on the hospital network level, my job was to make sure that, say, trauma and neuro teams didn't crowd out the techs, and we preserved social distancing in the CT room. And to get the techs the PPE they needed to sort out what patients were and were not on which PPE guidelines. And so your leadership will evolve by the task. And if you take anything from the pandemic, it's know that don't limit yourself necessarily to imaging, physicians, or just interpretation. Take on those larger roles within your network, within your system, or within your practice, because people need that guidance. And don't make the unfortunate assumption that you're not qualified to do it. You're a highly trained physician and a generally intelligent human being. You can sort it out. You weigh the evidence, you look at the details, and you have reasonable discussions, reasonable disagreements, but you can easily make your priorities. So one of my priorities after our physicians, we had an easy transition to covering by teleradiology because everyone has home workstations in our practice already. So we went down immediately to one radiologist on site. That was actually early March before it really hit the fan. And then my job wasn't about radiologists. My job was protecting the techs and the nurses. And therefore my guidelines and my guiding light in that sense was pretty straightforward and easy. And so don't limit yourself, be willing to expand your leadership experience and potential, and we'll move on from there. Look forward to the Q&A. And don't be shy, because this gets real boring if we just talk to each other, which we will do.
Excellent. So yeah, if everyone can see, if you hit the chat function or the Q&A function, we can see that with everybody. And while we're collecting some of these, one of the first questions is, what obstacles did you face in implementing your leadership efforts? And that can be open to anybody if anyone has a specific obstacle they want to discuss.
I think for me, so I took over, it was part of the COVID recovery operations within diagnostic imaging. As a radiologist in an academic center, you have some contact with technologists, but there are a lot of interpolitical dynamics that you don't quite understand. So I think getting the political layout of the land and trying to understand the inner working dynamics, making sure that even though you're appointed as the leader, you're not stepping on, say, the operational leaders on their toes. And so sort of navigating that, understanding, and then just getting up to speed on the operations quickly enough to be able to anticipate it. And I think it was a little bit overwhelming because, as a young person or a young leader, you think maybe I don't know anything, but I think for COVID, there was, no one has ever experienced this before. So just being confident in the ideas that you have and putting them forward. And then, so I think, the hugest hurdle for me was just sort of understanding the political landscape, learning how to interact with all of the technologists, getting a really good understanding of the operations. And so one thing that I did initially was actually, I made there's sort of an operations manager who is in charge of all of the technologists. I actually made him walk the whole, I went to every single imaging. I went to the ER, I went to the inpatient, I went to the outpatient center, I went to every, imaging center that I was going to sort of figure out what to do. We sort of walked the floor, we talked to the technologists, we talked to the nursing staff, we talked about what are their concerns, what are they thinking about, to sort of get the lay of the land. And that's sort of how I handled that.
Yeah, if I can jump onto that, do not underestimate the importance of understanding how the imaging is actually accomplished. It's something I tell interviewees whenever they come to us, is like, that's great. We presume that you can interpret a CT, MR, or anything else, but how do you actually produce the images? And then don't neglect the people that actually do it, the operations and the processes that get the patients there. Patient transport, order flow, workflow, all of these things matter. And so IT, informatics, nursing staff, hospital operations staff, and the rest, yes, you got a crash course and had to deal with it in COVID, but honestly, on a daily basis, this just highlighted the necessity of understanding the whole radiology workflow and supply chain, as it were. And don't underestimate the importance of that, because you have an opportunity to show people you care. And when you care, and when they can see that or feel that because of your understanding of the tech circumstances, of their needs, of the nurses' concerns, yes, in a crisis that happens, but when you do it on a daily basis, when you put in the work and have that understanding, it comes out in any meeting or committee or conversation you're having. That's the kind of way to demonstrate the whole understanding and the caring process that will help you segue into other leadership roles, sometimes whether you desire them or not, because a lot of people skip those points. And so, and it sounds like a lot, but there's really not that much work.
Yeah, to piggy off what Kirk just said, you know, one thing for me that I experienced, I guess to piggyback off that, one way I was involved early on was sort of standardizing our verbiage on COVID-related imaging early on before the excellent RSNA paper came out. You know, trying to figure out what referrers wanted. Did they want to know, is COVID suspected or not? Did they want us to avoid using the word COVID? So, you know, we standardized sort of our group-wide verbiage there. And that really was a nice segue for me to tee up my group's MIPS macros that a colleague of mine and I, you know, worked through. And it really served as a good opportunity to get my group used to using some more templated phraseology for specific things as they needed to be said. And I've sort of kind of inherited this macro person for the group, and pancreatic lesions and all the different RADs and things like that. So it's kind of one of those things that Kurt just mentioned about it may roll you into a role you don't anticipate or necessarily want to do, but ends up being useful for the group. I guess as far as one difficulty that I experienced is early on, I had sort of a well-defined role in response to COVID, especially at that one particular hospital that I frequent. And sort of once we got over the initial hurdle, my contact people, they kind of had other, you know, more pressing things that were still challenges. After we kind of worked out the radiology kinks, it became a little bit harder for me personally, frankly, to keep engaged in those conversations, especially as a junior leader, when other people more senior or you were dealing with other things. So I don't have a great solution for that particular aspect, but it's definitely something, a challenge that I experienced in early, you know, junior leadership.
Yeah, the two things from what Dr. Ortiz said. One, never let a good crisis go to waste. Not my line, but I forgot what famous person said that. May have been Churchill, something along those lines. But two is as soon as you have a leadership position, start looking for your replacement. So there's a chat question about CT techs were questioning why radiologists would read from home during some of the peak times, and how did we handle those conversations? So that was a particular sensitivity for some of us at our sites. They saw themselves as being on the front lines, and then potentially the feeling of abandonment by the physicians who are technically supervising their work. And that is an absolutely reasonable opinion. And the way we handled it was basically communication. And so at various hospitals, the medical directors like me or some others who were in charge of those facilities, we made our saves available in excess of normal work hours. So the techs never felt like there wasn't somebody to talk to them. So an example would be in the beginning, and actually we probably made it almost 2 solid months, you know, we would CT all sorts of active COVID patients. If it was an active COVID patient that they wanted to send to MRI, we would usually find other options. And the reason was 2 things. One, it would shut down the MRI for a long period of time for the terminal clean, which would prevent other patients from getting care. And 2, it actually put the techs at risk because they would have to get into full PPE, climb in and wipe down both the inside and outsides of the MRI and clean the gantry. So it put the techs at risk. And so what they could see on a daily basis was me, for the most part, or somebody else working to protect them. And the same thing for the CT techs. I would be there and in the face of trauma when they tried to put 9 people into the tech's workspace that could fit 2, maybe 3 comfortably, watching a severe trauma get scanned and kicking them out and making them stand behind the lead shield in the CT room. They need to see somebody has their interests at heart. And so that's when those questions about why do the radiologists get work from home, those just dissipate. Those questions get asked when people feel like they're being abandoned. If they can see or feel that somebody has their interests at heart, those things become much less of an issue and never really brought up. And we still haven't gone back to full on-site staffing at most facilities. We're at limited staffing, and specifically at my site, we have one rad there at a time. They're there for, there's 2 shifts during the day, 2 8-hour shifts, 7A to 11P. Otherwise, it was covered by telerad. Now there's 6 to 7 rads that are covering it by telerad, but the one rad that's there, and then me as the department chairman, are basically available 100% of the time to take text, phone calls, or answer other issues. And then people don't feel abandoned.
Yeah, I just want to, I think I can't emphasize enough that making sure that your technologists feel like you're protecting them, because I think that that goes a long way in terms of not feeling abandoned. You know, we were really proactive in ensuring that they had the correct PPE, the right PPE. Whenever our institution implemented policies, we made sure that they made sense for the techs that were doing it. So for example, an example is like our ultrasound techs, right? They tend to be very close to patients, much more so than some other techs. And it's not something very, I guess, apparent sometimes to other, you know, if you're, you know, somewhere in hospital admin, you're just like, oh, it's just imaging. We don't need to have them in full gear. But, you know, that was something that we really tried to advocate, is like these patients, these techs could be potentially very close to these patients. We need to make sure that they have the PPE they wanted. You know, it takes time, but just being able to address those concerns and being able to defend them. And then the other point that Kurt made about like ensuring that the appropriateness of imaging is actually, you know, really defending if it's not appropriate for an MRI scan to be done on a COVID patient, then protecting techs in that and protecting exposure. And I think just really emphasizing sort of the principles that you're trying to do to be able to take care of patients, but also protect employees, I think really went a long way.
So go ahead, Dan.
I was going to say not too much to add. Same line of thought. It was really about keeping open lines of communication, even though we weren't physically on site per se. One of the things early on that was of concern to especially CT techs is, and a lot of X-ray techs as well, was they weren't necessarily getting notification reliably from the ER that this patient was PUI. So one of the things early on that we did to advocate for them is we said, no matter what type of imaging is being ordered, if the person is under investigation for COVID or has known COVID, that has to be on the requisition. That way the techs can respond appropriately. So just sort of those type of things, little small wins you can do on behalf of your technologists help in overcoming those challenges.
That's that open lines of communication. If I got feedback that any patient who was PUI as person under investigation, a potential COVID patient, or COVID patient did not get flagged appropriately, I was on the phone with the CMIO or leadership from ER, whatever unit they came from. And the techs know that, because as soon as they tell me, I'm closing the circle with them and getting them feedback saying, this was an error, it's been addressed, you shouldn't see that again. If you do, call me. And it's just those communications. That whole round trip takes 3 minutes, and it makes people feel secure, and it makes them feel like they're being respected as professionals, which they are. And it's easy to overlook them because it's easy to sit there and just concentrate on reading your materials, but you won't have stuff to read if those people aren't the ones generating it for you.
And so Dr. Chen, Dr. Patel, I know you both have residents at your institutions. Were the discussions around attendings reading from home versus residents different than the technologist discussion who had to physically be on site? And how was that messaging different if there were considerations given?
So for us, you know, we're in a little bit of a unique situation. We don't necessarily, we have residents and fellows who are on site. We don't necessarily always rely on them to do all of the clinical. I know it depends on the institution. Sometimes the residents sort of take on most of the work. That's not the case at MD Anderson. So we were able to let a lot of them, I think the goal was we separated people into workstations where they could be in a workstation by themselves, just so that they could continue the education part of it. When it became appropriate and you know, there was a concern for potential spread of, you know, COVID, you know, those residents were allowed to go back home and not really be on site I think there may have been, I think the one area was probably the overnight and the residents were there on site, but they're definitely isolated from any patient care areas. And that was sort of, you know, I think the concession was just that they're not, you know, being exposed to anyone potentially. So thought to be, you know, relatively okay.
Can I ask a question? I'm just curious, related to the technologist question, have any of you experienced resentment from other physicians because your staff was able to work from home and most of them were coming in? Anybody see that?
You know, it's a good question. If we had it, it didn't come out explicitly. I think a lot of the physicians were very used to radiology being somewhat remote. Most of our interactions are via phone, text, or other virtual communication options, as it were, if we're going to lump them under that category. And so I don't necessarily think it was noticed, but it wasn't noticed because the work was being done, phone calls when necessary were being made, and the radiologist that they're used to contacting first, which is that kind of stat point of care radiologist, because we have what kind of we call the bat phone at work. It's everywhere in the health network knows that, you know, 27977 is the stat radiologist. That phone's manned 24/7, and nobody could detect a difference pre or post COVID between how the work was being handled. There weren't delays. There was no turnaround time issues. Subspecialty studies were read by subspecialty physicians, and then all the other work was being done. So if somebody was belly aching about it, it's certainly possible, but it never bubbled up to where I was aware of it at my institution, or we ever got aware of it being an issue for any of our customer service stuff.
Great.
I will say, you know, an interesting thing is that we never really had a huge peak like everyone did in the Northeast, like in New York City or anything. But there was an interesting phenomenon where, because we're primarily outpatient, right? We do have inpatient facility, ICU, all that stuff. But for example, I'm a neuroradiologist. So I deal with, you know, we deal with clinicians who are a lot of times outpatient clinicians. And so I work in an ultrasound area, and actually what started happening, especially with telehealth, was that the clinicians would see their patients electronically over camera, and we would be the ones that would be actually seeing the patients in the ultrasound area and biopsying these patients, and, you know, talking, like, we would be the only physical contact or human contact of patients. I'm sure that the breast radiologists experienced similar issues where it's like there were no physical exams done on the patient, and the closest thing to a physical exam was the ultrasound and the radiologist there. So I thought that was an interesting phenomenon that happened. And in fact, our clinicians were, like, our referring physicians were actually really good about, like, trying to let us know that, you know, a patient ended up testing positive, and they were like, oh, you biopsied this patient tested positive, we just want to let you know. So I really appreciate that they kind of had our back and recognized that we were sort of placed in that position that they didn't have to, you know, be in.
Yeah, and I'll just echo what Melissa was saying. So our practice, we were really fortunate that we all have remote workstations at home already set up. So for us, like, the transition for the pandemic was pretty smooth in terms of our workflow, and we still most are, you know, still working from home when we can. Particularly the person taking call is reading from home, and it kind of like what Kurt was saying, as long as the work is done, nobody has really said anything. They really appreciate how our turnaround times are very fast. But I will say to Melissa's point, that I think that particularly in the pandemic, I think the value of the breast radiologist really was at the forefront, because we were, you know, I was there every day at work. I mean, I still am. And, you know, those of us who do read breast, and seeing these patients and scanning them if we need to, and talking to the patients. And so the primary care providers really relied on us for that, you know, what our clinical suspicion was, our expertise. And very interestingly, after, you know, once we reopened, particularly at our main comprehensive breast center in Kansas City, a lot of our referring providers are pulling their patients who are having imaging elsewhere, like screening mammography, and they are now coming to us for, you know, from top to finish. So I think that the pandemic, if anything, there's a silver lining there, where our primary care providers really saw the utility, the value of the radiologist, and we're not just in our dark rooms all day, and that we actually are taking an active role in patient care.
I've had a slightly different experience. There's definitely some hospitals that are perfectly happy with having one interventional radiologist on site and diagnostic work being held remotely. Having that one person there physically on site, if clinicians want to come in and discuss a case or something like that. We're a general practice, so our interventionalists are fine pulling up an MRI to kind of discuss a case, and if not, then they can tag someone else remotely. So on most of the hospitals, that's been the case. There's been a couple of spots where one particular hospital, our interventionalists will handle most of the patient-facing stuff, even fluoroscopy type things. And if they're in a kyphoplasty or something and they have an outpatient study, having to have that delay, that started getting noticed at one particular hospital. So we did start bringing our one of our diagnostic people on site there to sort of fill in that gap. It wasn't a physician per se, it was more from a tech workflow perspective. And then there was one other hospital where we sort of have a hybrid now where we're on site 2 of the days, and then 3 of the days we're remote diagnostic. But again, we still have an interventional radiologist on site at all of our hospitals.
And one of the questions in the chat box is about schools are still closed to in-person education and parents need to be home. Do you still have radiologists working from home? That's a pretty heterogeneous spectrum across the country, even across different metroplexes. I know Dallas and Tarrant counties are doing it a little bit different. And it goes beyond just school. And we discussed this in a different webinar on parenting and COVID, but the schools may be heterogeneous between public and private. Daycares may be heterogeneous between where your kids are, depending on their age spectrum. But it also gets down to, even if you had nannies and they have potential COVID exposure, if you have tutors and they have potential COVID exposure. So what it really gets down to is scheduling logistics and it being a hot mess. And that's really kind of the baseline. And so, our RADs, that's one of the reasons we've stuck with the teleradiology model. There's and it's important to recognize, yes, we are covering things remotely, but everyone's needs on a site are being met. It's sometimes in excess of what they potentially had pre-COVID. And that's to enable those radiologists to continue to work remotely if they have to deal with virtual school, a nanny being gone, or supervising their kids. And so we've continued that, but don't believe that just made work easy and everybody's working virtually or doing teleradiology. That means a few people are doing a lot of work on site to make people feel like they have radiologists that are there and dealing with their issues, even when a lot of them are working off site. So there's no free lunch in that exchange. But yeah, absolutely, keeping people available to do childcare and other issues at home is exactly one of the reasons we've continued the exact same scheduling we had even during, I hesitate to say, the prior peaks of COVID issues.
Just to add on to what Kurt was saying, in terms of being making your presence available to clinicians, even if you're not physically on site, I think that a lot of us have kind of overcompensated, and in a good way. I think that it's helpful. So for example, whenever a clinician reaches out to me to ask me a question about imaging study, I'm sure others do this, but I will offer, hey, if you want to get on a WebEx or a Zoom call, I can pull up the images and we can review it, and I can pull it, do it real time with you. And so, I just did that just today. So, I think that's an option. I know it depends on how much time you have, but if it's for surgical planning, I think it's something helpful for them.
So yeah, the differential school position is likely to continue and be heterogeneous across the country for a while. It's interesting to hear how you guys have all adapted, and it sounds like that will be going forward. It's a related question was, what lessons have you learned during this pandemic? What would have prepared you better, if anything? And what do you think that you've learned that could be applied to a future scenario know Dr. Patel is hoping for not a second pandemic during her career, but what lessons can you take forward from this?
I think for me, one lesson I learned just in terms of a leadership experience was just, COVID allowed for things to happen really quickly because you had a team of people who were united on like a very urgent topic. And, a concerted effort was to make sure that all the right people were in the room whenever you had a meeting to get things done. And I think that that level of efficiency is something that would be helpful to take going forward in trying to get things done. That it is possible to move rather quickly and lead a team quickly to do a lot of stuff if you have the right people on board. And I think also knowing at what point in time do you need like sort of more political support from someone else above, external, internal. Those types of things I think were helpful for me to see that.
Yeah, I think one of the issues going forward is the value in both transparency and flexibility. And I pick those two specifically because transparency gets to that core of the communication and it gets to the why. Why are we changing? Why are we doing this? Why did we make all of these decisions in 1 week when previously we'd spent 6 months on it? And you don't want to have to create a burning platform for every important issue, but that's an important understanding to have, that knowing decisions can be made when people understand the urgency that's there. And what it comes down to is take that one step farther, and now your job is to help people understand the urgency for not just your COVID-related decision-making issues, but your other business, practice, quality, patient safety related issues. One of the reasons people don't feel compelled to make decisions quickly or work through a bureaucratic process is because they feel no pressure to make that decision. So if you have identified that something is a reasonably urgent issue, now people can do the work. You have to create the sense of urgency and that clarity of communication and transparency. It also comes down to, you think about all of the logistics and all of the changes that had to happen through changing schedules, changing shifts, working from home, having people off, having people on, potentially changing how people are paid. It is very important to be in an organization that's going to be transparent about how those decisions are made and communicating those effectively. And it gets really boring when you go through all of the leadership training and all of these webinars and people tell you the same thing over and over again about communication, but do not underestimate how important it is for everybody to understand what's going on, because in the absence of clear communication, what you're going to get is myths, urban legends, and random conspiracy theories about I am being targeted or they're doing this or they're trying to fire people. If you don't communicate, somebody will fill that void with something else. And so down to the flexibility, that comes down to a little bit of culture, a little bit of preparation, and sometimes a willingness to delay gratification. So one of the reasons we were able to transition very quickly into a near 100% teleradiology experience is because we had built that infrastructure beforehand, but that costs. And so it's a private practice. Anything that costs money takes away from the salary that the radiologists are going to make. But that was something that immediately benefited everyone in the group. And then the delta between where we wanted to be from a virtual experience to where we could be was very, very small. And it was easy to make that transition, but it was also part of the group's culture because they had prepared for it. That's how we handle hospital downtimes. We have redundant circuits to deal with when hospital IT inevitably about once a year takes themselves off the grid. So we have an ability to cover those situations. And if your group is prepared for those situations, then every other crisis has a pattern and a schema that you can stick to, and you'll have a solution for it. So don't underestimate the importance of kind of transparency and communication, but also flexibility. And that's a much more amorphous term, that flexibility, but it goes to your ability to respond to unanticipated issues.
Yeah, and I would agree with Kurt. Especially during this pandemic, as more information was coming out, as I'm sure the other panelists can attest to, we had to be flexible. We had to maybe, strengthen one safety measure or kind of modify another safety measure. And so flexibility was such a huge part of it. I think when you're a young leader in a big position, I think that in times such as these, you have to exude confidence and you have to ensure that your team knows that you got them, and, you know, so to speak. Especially with our technologists early on, very, very nervous about being in such intimate contact with patients, very nervous that we were going to run out of PPE, and that they were going to get exposed, because, as you know, in breast imaging, these technologists are very intimately in your face. The breast radiologists are very intimately associated with patients when we do biopsies, whether it's stereotactic, MRI, ultrasound, and when we're doing essentially wire localizations or seed localizations for lumpectomy. So just really, you know, kind of exuding that calm, confident demeanor for your team in times of crisis, I think is important. Because if you're a young leader and you show that any sort of anxiety, or you're wavering, or you just don't seem confident, the team just starts to unravel. And so even if internally you're like, oh gosh, like, I don't know what's going to happen here, exude confidence that, hey, we got this. We just have to work together. We have to remain calm, because especially like in a field such as mine with breast imaging, if we do not exude calm, you know, a calm, collected demeanor, our patients freak out. You know, our patients are already on edge coming in because they have a symptom, or, you know, they're worried they have breast cancer. And so if we aren't calm, the patient's going to pick up on that immediately. And so that, for me, that was very important to learn, that even though there's a storm brewing, you have to remain calm, cool, collected during the storm.
I think along those lines, you know, when it's sort of the same concept, but with your more senior partners, because this sort of talk is about junior leadership. So if you're presented a position, an opportunity to demonstrate some leadership in a scenario, just like Amy just said, even if you're not fully aware of what's going on, make all the checks you need to, phone a friend, do all these things. And then when it's game time to put the face on, then you can, you know, hit the ground running with it in front of your peers. The other challenge is, if you don't have that confidence, they're less likely to sort of buy into it. And if you're having to have your more senior partners make a practice change, if you don't have a well thought out process to advocate for that change, you're going to come against resistance, just because human nature is to, you know, the path of least resistance, and sort of minimizing effort and maximizing efficiency. So if you have to do anything to modify workflow, making sure you keep a clear case, not exude so much confidence that you're stepping on toes, but striking that balance of sort of shepherding your more senior partners to make, you know, right decisions as a group.
Yeah, I think actually, I just want to, off that point, this is sort of a rough technique actually as well, is sometimes you may have like a brilliant idea and you like know that whatever someone is saying is incorrect above you. But if you can somehow nudge the conversation so that they feel like it was their idea and it was their, basically have them come to the conclusion, it is so much more effective, especially as a young person who may not have influence, like being able to have someone above you come to the conclusion, even if you jumped there 10 times ahead. It's better for them to say it than for you to just flat out tell them, you're wrong, this is what we're supposed to do. So that's one thing that's important.
The other technique I like akin to that is play the mentor card, where it's like, help me work through this thought process so that I can understand where you're coming from. And if you walk through the process and you kind of interject a little bit of your own perspective, then you might be able to frame the conversation that way.
Yeah. This all falls into the category of managing up or leading up, but it's respecting people's positions, institutions, and histories there. And so it's a sensitive balance, but what's most important is for you to be aware of it. You don't have to be a masterful, you know, rhetorical negotiator or you know, a magician with interpersonal relations. But if you kind of just understand the baseline of people like to be respected, nobody likes to be wrong. They're very rarely going to be wrong on purpose. I think you can work through a lot of these issues and recognizing those sensitivities. If you don't like to be pointed out that you made a mistake or you were a jackass in public, they probably don't either. And so while tempting to flog them with CDC guidelines or something that you just read on your phone prior to the meeting, maybe a more sensitive approach is warranted. And I give these examples because I've either been tempted to do them myself, have done them myself, or have watched them happen to my own chagrin when we're trying to get something done and somebody took it down in flames. And so, you know, being sensitive to the room is very, very important. And I'll give you another ruck technique is if the room is going in your direction, if you wanted a decision to be made and that decision is getting towards where you wanted it to be, don't talk, don't bring it up, don't interrupt the flow, just let it happen. And then it's somebody else's idea, somebody else's success. You're getting what you wanted anyway. You don't always need credit for it. Just let it happen and then be happy that it came to that conclusion. Doesn't matter how it got there. If it got to where you wanted it to be, that's where you wanted it to be. Be happy with that and just roll on to the next battle.
So we're getting close to the top of the hour. I wanted to circle back. There was one comment earlier where you started talking about schools being closed and childcare, and there was a mention there was a previous YPS webinar about parenting and childhood, and there's definitely going to be a recording available of that, I think. So I would encourage everyone to reference that one as well. And then if you have any other questions that we were unable to get to during the webinar, please do send them to yps@acr.org or rli@acr.org. We will forward them to the appropriate panel members and get you an answer. I did want to give each of the panel members a chance to say, you know, what's your one key takeaway from this leadership one piece of advice you would give to young leaders looking to sort of take charge in their practice? And I'll let you pick your order.
I guess we can go alphabetical. This is easy. So I'll say that, you know, if you're interested in a leadership position, you know, take advantage of small opportunities that you're given. Don't underestimate an opportunity that's presented to you. Don't think that anything is too menial or you think that that's not going to get you to a position that you want. Really take on any task that someone has given to you and like just excel at it. And that will really carry you farther. And I think you can't go in expecting it's going to be easy, and that you can't go in expecting someone to just hand you title of like leader. You really have to earn it. And I think that once you demonstrate that, it'll just fall naturally for you. And so I think that's one thing. And it's work. It's not like, oh, I'm just going to get this title and I can, you know, especially in academics, I think that's what people look for, is just something to put on their CV, but really, you know, put the work in and take advantage of people around you to help you. Be humble enough to get advice from people when you're taking on these roles. And especially, I mean, I know that, you know, there's always a fight with administrators, but a lot of times they can be your ally, and really trying to figure out how to work with them can take you very far.
Just to piggyback off that, I was just thinking, I don't even know what the term piggyback means. Maybe Dr. Lexa knows since he has a couple pigs, but so, you know, even if you're early on and you're kind of just, you know, starting the practice and you're not necessarily sure what sort of challenges are facing the practice, it never hurts to go to more senior people and say, hey, what sort of challenges is the group facing that I might be able to help contribute to? Any problems that the group's having that I can contribute to solve? I think that's sort of one of the first steps, early steps, that once you're getting your feet wet, if you're not the type to kind of see the lay of the land and sort of spot the challenges on your own, I think that's really important. And when hospital administrators start seeing you be active in sort of these discussions, they'll start, you know, shooting you texts at 7 in the evening, being like, just had one from a hospital administrator, hey, when you give more, we're trying to rework our protocol for this, you know, being very open to those conversations starts your ball rolling to sort of develop those relationships with hospital administrators and more senior people in your practice, and really snowball into getting more significant challenges presented to you because they've been able to trust you with more less severe challenges.
I would say that, you know, just again, kind of adding to both Melissa and Dan, I think that if you have just even a modicum of interest in leadership and you are sort of nervous on the fence, like, I don't know if this is the right time in my life, or, you know, whatever your personal situation, whatever is, I think that the sooner that you can, you know, manage that and get involved in a leadership position or any, you know, whether it is a small leadership role to something larger, I personally feel that you should take that opportunity sooner than later. I think that, you know, if you are offered that, you know, regardless of what practice you're in, whether you have mentors in your practice, there's a cadre of mentors in our field of radiology that are here to support you and guide you. You know, we panelists, we are here to support and guide you in any way. Because if you are feeling something, we've probably felt that about 1,000,000 times at this point, or, you know, 100 times or whatever. So, you know that you are supported because it is taking a risk. You know, when I assumed this leadership role 2 years ago, a lot of people, particularly old, you know, more seasoned radiologists would say to me that, wow, this is a big role. Are you sure you're ready for this? So you are taking a leap of faith. It is a risk. But, you know, the risk can really just, you know, pay itself 1,000,000 times over, be very rewarding. So I would say, you know, just have faith in yourself, take that leap of faith, and regardless, you are supported, whether it's within your practice and or the field. We are here to support you and achieve your leadership goals and help you navigate through those difficult circumstances.
Well said. Small points. Don't be afraid to learn by doing. You do not have to be fully qualified to accept the position that you're interested in to have that position and even succeed at it. It might take work. It might take discussions with mentors. Everyone on this phone call has had text, DM, and other sidebar chats to sort out leadership problems, knowledge issues, or other stumbling blocks along the road. But to get back to what Melissa said, don't be afraid to take on those roles. As was said to me by one of my ACR mentors early is, you know, the answer is at the beginning of your career, the answer should be yes. You kind of have to earn the right to say no to some of these opportunities and positions because they build on one another. You build, like Dr. Ortiz said, you build on the successes that you've had, the roles you've had. Like Dr. Chen said, once you take on these roles and you get that experience with other administrators or physicians, they see you, they get used to seeing you, they get used to dealing with you, and that's how you progress to those other opportunities, which is why, to get back to what I said earlier, always be working on your replacement so you can segue into a different role eventually. But I'll leave you with one of the pieces of advice I got is everyone above you, committee chair, administrator, practice leader, whoever, has a good portion of their job that they don't like doing, but they have to do it anyway. If you can figure out what that is, take on that responsibility and get it done, then they will appreciate you, they can mentor you, and that will ease your path forward. And for other people on the call, I always feel like I Forrest Gumped my way into wherever I am now by just accidentally getting stuff done. But it very much gets down to doing work that other people don't want to do, gets you into a position that where you will do the work that you enjoy doing the most.
Excellent advice. So I wanted to thank everybody for being with us tonight. Look for a follow-up email from the ACR. We'll get other information out to you. Look for more webinars from the YPS to come as the year progresses. I'll thank our panelists again, and I will turn it back to Dr. Lexa for some closing thoughts.
Well, I just want to thank everyone who attended and everyone who spoke. I think you got a tremendous advice here. They're just things that I wish somebody had told me when I was your age. And that's one of the goals of the RLI, is to do the things like this that and no one may come up and tell you that, you know, it's time to lead, just get started and get going. And you heard some great advice about how to, you know, how to handle a crisis. You heard great advice about how to gently influence people, which is critical when it's your age. And, you know, one of the things that, you know, I have in my own book is, you know, leadership is not a title. And I think you heard that from every speaker today. It's really about doing. And sometimes it's leading without being in charge. And sometimes the best leadership in a crisis, you know, is the people who step up. And there's a cliche in the military about a battlefield promotion. It's the person who steps up and takes over when the leader either fails or the leader's gone. And I think you just heard tremendous examples here of leadership in a crisis. So I just want to thank everyone.